Good evening, everyone, and thank you for joining what we call Rotary Talks. And it's going to just be conversations with persons within the community, sometimes persons without the community, but at least within the Rotary community as well. Just really connecting with themes for that particular month. And this month, well, if you join the webinar, I hope you know the theme for the month because you would have joined the webinar, right? So this month we're focused, our theme for Rotary is focused on maternal and child health, right? And we're going to just talk to two professionals within the field, and they are going to help us kind of understand their rules as well as some do's and don'ts, things to note from there. So if you have a pen and pad, this is where you pull out for your notes and you get ready, right, as we begin from here. So let me introduce myself. I'm Shurla Collins, the immediate past president, as well as this year's public relations chair. And I would just be the introduction and closer to the end and part of the things, right? And I'll be in the background from there. But I do want to introduce one of our Rotarians who's going to introduce our guest speakers today, right? Rotarian Coretta, you want to come to the, well, I say in the stage, but come to the forefront, right? As we kind of introduce the public to what we're going to discuss today, but more importantly, introduce our speakers. So I'll pass you all now to the hands of Rotarian first.
So good afternoon, everyone, and thank you for joining. I have the pleasure today to introduce two wonderful persons. They work well in our community, and they're actually people who live in Point Fortin as well as work in Point Fortin. The first presenter is Miss Richelle John. She's a medical social worker at Point Fortin Hospital. She's one of the very hardworking and astute, zealous medical social workers we have who go above and beyond to try and facilitate patients. We work closely with her on the maternity ward, especially when it comes to patients who have challenges or issues, as well as she works experience right now is through in terms of the maternity ward, as well as we're dealing with maternal and child health. She'll be presenting some information about what she does and her experiences as such. And also we have Miss Shurla Monsegue. She is a registered nurse for 17 years and a midwife for 11. She's very passionate about women and their well-being. She's focused and dedicated to the overall health and well-being of women and their babies, and by extension, the whole family. I'm not going to go into too much detail because I know Miss Richelle John will be talking about it, but just generally speaking, I'm just giving an idea of what maternal health is concerned about. It refers to the health of women during pregnancy, childbirth, as well as in the postnatal period. And it is one of actually the sustainable goals of the WHO, the World Health Organization. The aim is by 2030 to have less than 70 per 100,000 deaths, maternal deaths, per live birth by that time frame. I think right now Trinidad and Tobago is on target with it. So we hope to continue and provide information that can hopefully assist the general public, as well as the mommy, to pass on information to mommies and the family in general in terms of how to assist in attaining this sustainable goal. In terms of child health, well, we all know children are up until the age of 18. So it's similarly, it's about health and well-being of children up until that age group. It includes vaccinations, just general well-being and health and care of patients, education, all those things. And in terms of the WHO, one of the sustainable goals is to prevent deaths of newborn and children under age 5 years within all countries by 2030 as well. And it's also to aim to to at least have as low as 12 per 1,000 neonatal deaths per live births, and under the age of 5, they want to aim to have a mortality rate of less than 25 per thousand. So hopefully this evening we'll be able to kind of engage persons in terms of what's our role, what's the medical social workers' role is, and generally the midwife's role, and then also to the general public, what we can do to help assist in bringing this forth. So I would like to give the floor to Ms. Richelle John first, and I give her a warm welcome, and she may go ahead.
Good evening again. As mentioned, my name is Richelle John, medical social worker that is attached to Point Fortin Hospital. I've been a social worker for the past 9 years and practicing at area/Point Fortin Hospital for the last 4. So I'm just gonna explain our role as my role as a medical social worker, but I represent my department, hence the reason I'm saying our. So my role as a medical social worker, and as it pertains to maternal and child health. So social work is a profession by which trained professionals are devoted to helping vulnerable people and communities work through challenges that they may face in everyday life. The roles of a medical social worker as it pertains to maternal health, it varies and it depends on the cases by which we receive, right? I'm just going to give you a couple of examples and explain our rules based on these examples that are given, right? So some of the cases received by our department are expectant mothers with poor socioeconomic support, expectant mothers involved in domestic abuse relationships, expectant mothers who are non-compliant to prenatal care, and teenage mothers, right? The medical social worker role for persons with poor economic support. First, we have many rules. So there are many rules that would pertain to one case. So with regards to the persons with the socioeconomic problem, we help them, we counsel them. So we help them to cope with their current emotions as it pertains to their financial situation, right? The roles of a broker can also be explored. That is that we try to link them with external organizations that may help to curb their financial constraints. Example, social welfare, right? And advocates, we also advocate on behalf of the person. So because most times persons are unable to go, so it can be social welfare. So we become the voice of those clients as well, right? For the teenage mother, the role of the medical social worker is that of an educator. We inform. Information is provided in a way that is understandable to the mothers, and focus is made on the transition from childhood into motherhood. The role of a counselor is also explored, so we deal with their emotions as well. And it should be noted that teenage pregnancies, the families most times are affected. Though the child is involved, the teenage mother is involved, the parents are also affected emotionally. So counseling goes not only to the mother, to the teenage mother, but also to the teenage mother's parents as well as the teenage mother, the father of the child. Most times, that's if we find out who the father is, that's a story for another day, right? It should be noted that care planning, we also take the role of a care planner post-pregnancy, because most of these teenagers, they are involved in school, right? So we see to it that, well, I see to it most times that they get back into the school system, right? And if most times they don't have a desire because baby nice, baby cute, coochie coochie, they want to play, they want to, it's a new world for them. But at the end of the day, we emphasize that education is important. So most of my teenage pregnancy, I really, really, really stick to them in terms of they going back to school and getting their education. And I have had a lot of success with regards to those teenage mothers that I have came into contact with, well, most of them to see. For those who are the domestic abuse relationships, teenage expectant mothers, sorry, the role of the counselor is also explored. The role of the advocate is also explored. The role of the educator. So for persons who are involved in domestic violence, there's 800 SAVE. So most times they don't know about the 800 SAVE. They don't know that they don't want to make a report. So I'm talking about from my experience, I have become the advocate whereby I called 800 SAVE. I linked the home for the person. I'm the person I'm the broker. I'm the person in the middle, linking the resources and making sure that everything runs smoothly for the client because of the fact that sometimes the trauma, they can't deal with it for themselves and they need that voice, right? And for the non-compliant mothers, the role of the social worker is counselor. Well, one thing we know that we counsel. We counsel and we educate and we advocate, right? So for the non-compliant mothers, there's the counselor. We have them cover their current emotions. There are many reasons as to why mothers are non-compliant. Persons have their own thought processes, right? A mother may think that, well, I have 5 children and you see the 4th one I already didn't take much, and you see this 5th one I already can't make to take the medication, it have me feeling sick, or financial reasons, they can come to get the medication. Whatever the case, we explore whatever the person challenges are, we adapt to the role, right? The educator, we explain to them the importance of the prenatal care as it pertains to the development of the fetus and supports the overall, and also how it's important to the mother as well, right? Now that is basically dealing with the maternal aspect of it. Now post-pregnancy, meaning persons who, well, after the pregnancy, this is where the child health comes into play. So as a medical social worker, but child health is a state of physical, mental, and intellectual, social, and emotional well-being. So as medical social workers, we tend to make sure that the child is properly well taken care of, right? So it's not, and I just want to make emphasis that it's not like, well, baby born, so mother is no longer, and it's no longer important, but it's just that the child health is important as well. So we work alongside the mother and the child for the well-being of both the mother and the child, right? So we make sure as social workers, our role is to make sure that the mothers visit their clinic appointments, not only for the child, but sometimes for the mother. There's a 6 weeks. I think the doctor can, after 6 weeks, you have to visit your clinic. So you make sure that the mother does what is needful for her as well as the child. All the clinic appointments supposed to be is mandatory. And well, I can speak for myself. I make sure that especially with my teenage mothers, I try my hardest to make sure that they do that which they need to do. Because for me, I think that is most, those with the teenage mothers as well as those who are financially constrained, they tend to lapse a bit, right? Breastfeeding, we educate the mothers of the importance of breastfeeding. However, it's up to the mother if they decide to breastfeed the child or not, right? That's from the medical social worker standpoint. We ensure that the babies are vaccinated as said before, and we ensure all milestones are met. So sometimes for me, after the teenage mother, the role of the medical social worker, we do a home visit before the baby is born to make sure that the home is prepared for the baby. We also do a visit after the baby is born to make sure that everything that was stated that you needed to do was done, right? So, and that is, for me, even up to Friday, I do impromptu visits, especially after, because sometimes persons tend to, when you call them, the place that tend to be a little too perfect. So I want to see you in your I want to see you in your elements. I want to see what you're really doing, what state of mind you are in. Because most times this will show whether it be postpartum, whether it be that the person probably need a little more assistance, the social support is kind of uproar, they don't have that support that they need. So sometimes, or probably could just be, they just need a little, they need to know how to clean and take care of themselves a little more, right? So for me, I do impromptu visits, especially with my teenage mothers. And the role of the social worker as pertains to child health is to ensure all milestones are met. And all milestones meaning vaccinations, meaning the child is in school, the well-being of the child in terms of the shelter, everything is okay. And the child is in, and the end result is that the child is, all physiological needs are met and the child is enrolled in school, and at the end of the day, we can't, as medical social workers, though we do this, there must be a cut-off point. So once you are comfortable with, okay, mommy is okay, child is okay, they are now in a place where they can stand on their own 2 feet, and if you think that the mother is capable of doing right by the child, and we then terminate the case, and that's it. So basically, in a nutshell, that's the role of the medical social worker. We more counsel, educate, we advocate, and we are the brokers for mothers as well as their children. So thank you. Any questions?
So I was going to leave the questions to after to combine with both Ms. Shurla and you, if that's okay with you.
That's okay, yeah?
Okay,
Thank you.
great.
All
You're
right.
welcome. So Ms. Shurla, are you there? Ms. Monsegue?
Yes, I am. Good evening, everybody. My name is Shurla Monsegue. As Dr. Juve would have said before, I am a registered nurse and a licensed midwife. And I also have the privilege of being the head nurse of the obstetric and gynecology department at the Point 14 Hospital. So apart from that, what I didn't put in here, I'm also a mother of 4 children. So information that I come to give here today is not only from work experience, but also from my personal experience. So today I am doing a little bit on the do's and don'ts of pregnancy. So I know I may not have a wide catchment of people here, mainly being pregnant women. However, I hope that the information that I share today is something that, y'all could take and carry back to somebody, carry to a sister, a cousin, a friend, somebody who you could give information to. So as it starts, pregnancy for most women and their significant others is a momentous time full of joy and anticipation, and even the occasional doubt. This holds true for first-time mothers as well as women who are already mothers. No one is ever truly prepared or truly clear as to what it means to be a mother, since motherhood does not come with a manual, and every pregnancy and child is different. So for my do's and don'ts, I broke it down into 3 main categories: the preconceptual, which is the period before the pregnancy; the antenatal period, which is the period where the woman is actually pregnant; and the postnatal period, which is the time after delivery, which lasts up to a period of 6 weeks. So it is important that before, women and their partners make the decision to have a baby, that they have their preconceptual counseling and care. This provides the couples with an opportunity to talk with their healthcare provider and to voice their concerns and their desires, thereby allowing for proper choices to be made. Things that can be discussed with their doctors include personal and family history of medical conditions, such as diabetes, hypertension, sickle cell anemia, HIV and AIDS status, other sexually transmitted diseases, which is like your syphilis, your gonorrhea and such, Down syndrome, and blood conditions. Previous pregnancy complications, healthy dietary practices to prepare the body for pregnancy, such as in the woman with the low blood count, medication history, and drug and or alcohol abuse. In the antenatal period, it is important for the woman to visit the antenatal clinic, obstetrician, or the general practitioner regularly. This can be done as early as upon finding out that she is pregnant. This allows for early commencement of antenatal care. It allows for blood testing to be done early, for anomaly scans to be done early. So the anomaly scans are the scans that would usually be done to detect any birth defects or any problems with the baby or the mother, and for commencement of supplementation earlier, right? The woman should speak to their healthcare provider about any concerns they may have, despite how trivial it may seem. As I said here, ask questions, ask questions, ask questions. It is the only way that they can know and get their concerns, dealt with. As the saying goes, there is nothing like a foolish question. Do ensure proper dietary practices. Note, and this is important to note, it does not mean eating for two, as some people tend to think. It's not about eating for two. You're eating one meal with enough nutrients to supply you, the mother, and the growing baby that's inside. You need to have a diet which is rich in iron to build up the blood count. As we know, the blood carries the oxygen in the body to the organs and to the tissues for both the mother and baby. And it is important to maintain our blood count to meet the demands of the baby. Folic acid, which is, as they say, the building block, it is necessary prior to conception and in the first 12 weeks of pregnancy, as it helps in the formation of the nervous system and prevents in the baby from falling risk to neural tube defects. Both folic acid and iron can be found in your dark green leafy vegetables, while folic acid can also be found in your carrots, your potato, your fruit juices, also pumpkin as well, just to name a few other sources. It is important that she ensures adequate rest and exercise. The growing fetus, as well as other activities, tend to take toll on the woman. Adequate rest ensures that the body is not only to repair itself, and it also prepares itself for other activities. Exercise is important for the woman to assist in the proper blood flow throughout the body. It helps to build muscle and it helps to maintain proper weight. Now, when I say exercise, I don't mean going to the gym and lifting up the heaviest weight that you could find. I don't mean preparing for Ironman challenge or anything like that. I mean a little thing like, a little walk, little stretch and all of that, because, you're helping the pelvis, you're helping everything, to prepare itself. It also helps the woman in her body returning to the pre-pregnancy state a lot faster, because you have all the muscles and all the tissues are taut. So, after the stretch and the delivery, everything comes back in place quickly. Do involve your significant other and your family in the process. A lot of us women selfishly keep the men out of the process. They are contributors as much to the whole process as we are. And, it helps to make the journey a little easier, knowing that you have somebody there with you to offer you a little back rub, a little foot rub, bring a juice, bring a pillow, a little warm something, Do engage in sexual activity unless it is contraindicated. Now, this is a kind of touchy subject for some women, because some women are afraid, but unless it's contraindicated by the baby, I can assure you, as well as Dr. Juve could assure you, there's no way it is touching the baby. There's nobody that's skilled enough to touch the baby. So, it helps to soften the pelvis. It helps to prepare the pelvic bone for delivery of the baby. The pregnant woman should be prepared for breastfeeding at birth. Breast is best. And I will repeat it again. Breast is best. They should read and gain as much information as you can during the pregnancy to discuss with your healthcare provider, but also to prepare for what is to come. Because, a lot of first-time mothers come in the labor ward lost and not knowing what to do, very much afraid, very much doubting themselves. So, you read, they go on YouTube. There are so many videos here, so many videos available now that they could use, to help them be a little knowledgeable when they come into the labor ward, that they could prepare themselves, right? And they can also attend childbirth classes, wherever they are available. So I give a little plug for myself here. Our hospital has Lamaze classes, which are available to mommies and their significant others, daddies, aunties, grannies, anybody who they want to come into the labor ward with them. We have that service available at Point 14 Hospital. It's a brand new service we now kick off. So, Tell a neighbor, tell a friend. We have that service available there. Right? So they should refrain from smoking and alcohol consumption, because babies born to smokers tend to be smaller. They may frequently have respiratory problems within the first year of birth. Women who smoke are also exposed to a greater risk of premature deliveries, stillbirths, and low birth weights. Passive smoking also exposes the woman and her baby to risk. It has been said, research has said, that passive smoking has been linked to sudden infant death in some newborn babies. Babies born to alcohol drinkers tend to develop a condition called fetal alcohol syndrome. The alcohol that the mother consumes passes from the mother to the baby while in the uterus. The babies, unfortunately, are unable to process the alcohol well, and it remains within their bloodstream up until the time of birth and beyond. This can cause the baby to be born with physical problems, behavioral problems, and experience difficulty in learning. Some of these babies tend to be very irritable. It is almost as the, how they would say, as almost as if the baby is having a withdrawal symptom, because the baby has been so much dependent on this alcohol throughout this 40-week gestation, and now they are out and they don't have alcohol. So it's almost as though they are experiencing withdrawal symptoms. Right. Do keep any important information about your health. Do not keep any important information about your health and previous pregnancies from your midwife or your doctor. These are the people who are responsible for your care and that of your baby, and all information is important. There are a lot of things that women may feel are trivial, but they are very much important to us. They are things that are red flags to us that we need in order to prepare for, this pregnancy, to prepare the care that we have to give you through pregnancy, and even the care that we have to give you after pregnancy. Do not take any medication that is not recommended by your doctor. They may have disastrous effects upon your unborn baby. Do not miss your appointments with your midwife or your doctor. Each visit is important to charge in your pregnancy's progress and the development of your baby. So now we reach to the period after the baby is born. So it is important that the woman ensures adequate rest, as this is important to allowing the body to return to its pre-pregnancy stage. So it takes about 6 weeks for this to happen. It takes about 6 weeks for the heart to return to normal, for the bladder to return to its place, for the stomach to return, because when that baby comes, that baby throws everything into a tailspin. The baby moves the stomach, it moves the bladder, it moves everything. So, it takes 6 weeks for the body to return itself back to how it was pre-pregnancy stage, pre-pregnancy blood volume, pre-pregnancy everything. So it is important that the woman gets much rest. They say that a woman is supposed to get her rest when the baby is sleeping. But as a mother of four, I know that is absolutely impossible to do, because the time when the baby resting is the time when you want to go see how quick you could cook, make a quick sweep, make a quick fold, do a lot of things. But so, as I say, it is important to get your rest. Know that you have to rest. Know that you need this time of rest. You may not be able to get it when the baby is resting, but as much as possible, engage your family, engage everybody, so you could have that period of rest. The mother needs to understand that it is a normal thing to feel overwhelmed. It is a normal thing to feel stressed. It is a normal thing to feel like, if I don't know what I am doing here, especially for the first time mother. The second time mother, she have a little advantage because she knows what it is. I've been down this crazy road already, so she knows what it is. She knows how to prepare. She knows, hey, I know what to do. But the first time mother, it is a new thing for them. It is a new thing for the baby. This baby has been inside for the last 9 months. I've been inside my mother's belly. When my mother cries, I cry. When my mother eats, I eat. Anything that happens within my mother, they have such a close bond. So it is, when a baby comes out, they can't talk. They can't say how they feel. So they tend to cry. and they cry a lot, and they cry for everything. And unfortunately, for some first-time mothers, they cry too. So, you know, you have some sessions where baby crying, mother crying, nobody doesn't know what to do. Nobody can help anybody. But it is okay, and the mother needs to understand it is a normal feeling. It is a normal, you know, in my experiences on my ward, you know, there are mothers who would feel embarrassed to know that they're overwhelmed, to know that, you know, okay, I can't deal with my baby and I don't know what to do. And they feel, you know, a pressure to ask for help, but it's a normal thing. It's something that I always try to tell them. It is normal. Don't feel embarrassed. Don't feel hurt. That's what we are there for, to help you through the situation, help you through it. It is important that, as I said before, that the postnatal mother seek out the help of friends and family when needed, especially when you are overwhelmed. Know that I need that time. Know that I need somebody there to help me, to take this little burden, to help me do something that I don't know how to do, that I never knew how to do. That's a first time, that's a test that I believe I'm about to fail, you know? And again, a plug for breastfeed, breastfeed, breastfeed. Breast is best. There is nothing better, once it's not contraindicated for a baby, than breast. I usually joke with my mothers and tell them that, you know, humans are the highest in the standing, and yet still, you know, we would never see a cow or a goat or anything like that in a supermarket going to buy milk for their babies. Yet we go buy milk, we take all these artificial products and we push it in our baby's mouth. And, you know, we expose our babies to so much of complications and so much of risk. We would be amazed and surprised at what breast milk is. Breast milk is referred to as liquid gold. Breast milk has everything and anything that a baby would need within the first day of birth to 6 months. They have the right amount of fat, the right amount of water, the right amount of nutrients, the right amount of vitamins. Everything that the baby needs is in there, in that little package. Something interesting about the breast milk too is that first milk that comes out, it's called colostrum. It prepares the baby's immune system for what it would need to take it through those first few months. It lines the baby's mouth and the intestine straight down to the anus and prepares the baby for everything that it is to come. Breast is best. Anybody coming on my ward should be prepared to know that breast is best and breast will be given. Breast will be given. I will not deviate from breast. Breast is best. I've seen it. I've been to conferences where you're seeing babies that are exclusively breastfed, who are fat and ripe and rosy, and it is best. And another important thing for the woman postnatally is to keep her 6 weeks appointment at her health center. This 6 weeks appointment is for both the mother and the baby. It allows the doctor to check up on the mother to see if everything is back in place, if everything is tucked and put away as properly as it should be. It is time for the baby, you know, to see if the baby has put on any weight, if the baby has, what has gone on with the baby. It is a time for assessment for them. It is a very important period in the postnatal time of a woman's life. So, on the side of the don'ts, after delivery, the woman should not engage in any strenuous physical or sexual activity before 6 weeks. This allows time for the body to heal and to return to its original state. Now, there's a very important plug here for the sexual activities. So this is something I need everybody to spread. That within that 6 weeks there, the woman is very vulnerable, and having sexual activity before the 6 weeks exposes her to the risk of having another baby quickly. So on the brink of being crazy with one, she's pregnant with another and set to go crazy again with two at the same time, around the same age. right? So if she thinks that, hey, this one has sent me crazy, then there's another one right behind waiting to come. So she needs to make sure that this 6 weeks time, you know, that she takes this time for herself and for healing. And it is important that, you know, she shares this information with her partner, and that he understands that this 6 weeks time is to prevent you from having to buy first stage Pampers and second stage Pampers at the same time. It prevents you from having to buy 2 different kinds of milk. It prevents you from a lot of things happening at the same time. And finally, and most importantly, and I stress this to all my mothers, do not be afraid to reach out for help. Postpartum depression is real, and it does affect a lot of women. It is a real thing. It is a real thing. You know, some of us would have heard about the things that happen to women. Women tend to unfortunately kill their children, harm their children. It is a real thing. It is something that, you know, I don't think much emphasis is really being put on it, and I pray for the day that we have much more emphasis on it, and that when we deal with our women, we don't deal with them physically, but we also deal with them psychologically, because it is important, especially for new mothers. And with that, thank you so very much for giving me your undivided attention. I had much pleasure in preparing this presentation. It made me feel fulfilled as a midwife. And I thank you, Dr. Juvie, for extending this invitation to me.
So thank you, Ms. Monsegue, for that wonderful presentation. And again, thank you, Ms. John, for your wonderful presentation as well. The floor is now open for any questions for anyone that anyone may have. I just had one for Ms. Richelle, Ms. John, sorry. In terms of your general experience with teenage mommies, how do you find that they are coping?
It varies, and the reason it varies depending on the social support system, right? So those who have the support of their family members, of their parents, they tend to cope pretty well.
The teenage mommies?
The teenage mommies, yes.
Okay.
So those who have the support of their parents, they tend to cope well. And those that don't have the support, some of them, because of the willpower that they possess, they cope well, but others, they tend to need a little extra help in terms of the coping within the coping process.
And in terms of follow-up with the children, after you discharge them, do you find that you get more referrals later on in life, like later when they are babies, and then later on you may especially want to have domestic issues or have difficulty with social issues? Do you find later on, even after the period that you have seen them, follow them up, and you consider them safe, later on, do you find that you get back referrals in terms of issues being issues arising again?
To be honest, and I think I speak on behalf of most of the persons within my department, certain cases we tend to not let go. So with regards to those domestic issues and children are involved, we tend to hold on to them. So therefore, if another referral comes, or if there's another referral, we already know that it is going to happen because we're close-knit to them. So it's either a long arm or it's never really severed. But for me, I haven't had a case by which I terminated and then see them in the system. Not while it was important at it.
And
if I may, Dr. Juvie, I hope you hear me clearly. The two factors I think we need to look at in terms of teenage pregnancy. One is the issue of religion. The other one is the issue of culture. Because basically among East Indians, it is maybe the okay for a child, because of their marriage laws, to have a child as a teenager, because they usually get married between the ages of, let's say, 10 to 15. And so that may be acceptable, but there's the extended family that supports that. Among the non-East Indians, for instance, like Afro-Trinidadians, where that's a taboo now. When you get pregnant that early, what kind of money I have? What kind of, I know. And so there's that kind of rejection that you suffer. And the child in that culture, with that religious perspective, because most Afro Trinidadians are Christian based, and of course having a child before wedlock, that's a whole issue. And so I think one of the things we need to do is to learn how to accept these issues and to work with them from both the cultural and religious issues. As a psychologist, I have had to really deal with not just the child, but parents and grandparents in order to bring that kind of stability. Because by the time the child is born, that child, the baby is affected because the mother now is going through depression, have all kinds of other psychosis, and then that child grows up with a removed displacement issue because the child either lives with granny or great granny, and the mother sent back to school. And so there's kinds of issues that I think we need to, and I think it's an excellent question, and maybe something we could look at another level and bring you back again, you guys, to maybe it's because this is a crucial issue, especially for me working in Central Trinidad. I have to deal with this thing a lot from my share, and I'm really happy for you to mention it, and I trust that we can do something further with it. Thank you.
Ms. Monsegue, can you tell us more about Lamaze classes and what does it involve and how does it help in terms of preparing the mommy and partner for delivery? Can you let us know a little bit more about it?
Okay, so basically Lamaze classes was started many years ago just as a way to teach women how to breed. You know, how to breed, the breeding process, because when they reach when they reach on that labor ward, they tend to not know what to do. And even if they know what to do, they tend to forget to know what to do. So the basic principle of Lamaze was about teaching the woman how to breed and how to prepare them for childbirth. But as time would have evolved, there was so many different aspects that was added into the Lamaze classes. They started to teach them little exercises, they started to teach them little way of coping, stretching, how to rest at night, how to turn, what to do, little stuff like that. And then we realized, I think everybody would have so I've seen everybody, I take it for granted, sorry. The laboring process is a type of, is a kind of a mental period for a woman because, she's laboring alone and you're there, despite much of what we try to do as midwives, we can't be with everybody while they are laboring. So I believe, a lot of what the woman goes through is dominated a lot by fear. And what we aim to do with our Lamaze classes is to involve the significant other in the class so that he could come into the labor ward with the mother. So as a part of our midwifery training, we have to do home births, right? And we have all noticed, studies have shown that the woman who labors with company, the woman who labors with a familiar person tends to labor better. The whole anxiety, the bawling, the everything, it is very much reduced because there's somebody there with you to help you through the process, somebody to coach you, somebody to give you encouragement, somebody to rub your back, somebody, as in some cases, somebody whose neck you could hold, and it helps because the woman feels like if she's not alone. So before, when we were in area hospital, it was something that we always wanted to bring on stream, but we didn't have space and we didn't have, adequate resources. But as we would have come into the whole new hospital and all of that, and in trying to keep, in the whole family aspect and making the situation a lot better for the women, we would have started our Lamaze classes. And we've had a few successes as well. And just a plug, even if somebody doesn't attend our Lamaze classes and they come with the woman to deliver, we allow them in because we know the effect of having a company, what it does to the woman, how it makes her feel. And it's such a joyous thing when this baby comes and she has somebody there to share that joy with her. Because for me, despite how I love my job, it is just a job. It isn't anything for me. It is something that I've come as wrote. But when this baby comes out and you have somebody to share that joy with you, it is such a amazing thing. So that's our trust with our Lamaze and our trust with having the partners come in with the woman into the labor ward.
Okay. Thank you, Shurla, for that explanation. It really sums up what it is about for you. And it has, in the short time that we've started, you do see the joy in both partners' faces to be involved in the experience. And talking from experience too, I would attest to the fact that having someone there with you when you're going through the experience does make a difference in terms of you don't feel alone. You get a little bit more motivation that you can do it. And then, of course, when your beautiful bundle of joy comes, you feel like if, it was well worth it in terms of you didn't have to experience it alone, you got to share it with someone else that is just as special to you. I see there's one question, this for both Ms. John and Ms. Monsegue. They're asking, are there any common challenges that you all consistently see within Point Fortin? I think Richelle asked from your point, both of y'all, from what do you all commonly see happening in the community of Point Fortin as it relates to maternal and child health? Who wants to go first?
I don't know this computer thing. I apologize to everybody. I don't need computers for my daily job, unfortunately. So sometimes this computer thing. But I think one of the problems that we have, what are we facing a lot is I think within recent times, we're having a lot of teenagers. We're having a lot of teenagers coming on the ward. We're having a lot of teenage pregnancies, and it's a time of doubt for all of them. It's a time of concern, and Ms. John could attest to that. And with the teenage pregnancies, you're having the mothers who are in a position where they don't want what they're having, and they're having because, right? And I guess that's basically it. We're still moving it. And we're having a lot of problems with the foreigners, sorry. And we a great language barrier because we're having all these Venezuelans who are coming in here. And unfortunately for myself and my staff, our first language is English. And it's hard relating to somebody who, when you say push, they look at you like, what are you saying? When you say don't push, they look at you like, what are you saying? So that's our challenges, our teenage pregnancies and our foreigners. That's the problem that we are facing right about now. I see there's another question for me, Dr. Juve. Could I go ahead and ask it one time? All right. So Ms. Jones, it's Sharice Jones, I saw her name as. So yes, we do have provisions in place for people who don't want to breastfeed. Yes, we do. Yes, we do. Unfortunately, yes, we do, because breastfeeding is a personal choice. It is the choice of the mother, even though we are guided by, you know, certain policies and stuff like that, as carried on by WHO and PAHO and the Ministry of Health. We have certain guidelines that we have to follow. However, breastfeeding is a personal choice, and as healthcare providers, we strive on allowing the mother to make an informed choice, that the choice that she makes is not based on what somebody else say or some other thing, that, you know, the choice. Okay, like there are some women who would tell you, I won't breastfeed because my breast will get big and my breast will hang and all these sorts of stuff, you know. We try to bring to them that this is not true, you know. Gravity takes the body no matter what, with or without breastfeeding. Gravity takes the body, you know. We try to bring to them, you know, the best information, the latest information. We try our best. However, if they insist that they are not going to breastfeed, we do have milk available.
That's not the question I asked. I asked if it says they cannot produce breast milk, what are the steps you will take? And what do you all do in that case?
It's the same thing. If they cannot produce breast milk, if they cannot produce milk, we have milk available. We have milk available. So I say it trepidatiously, yeah, but you know, we do have milk available in the hospital setting. It's not readily available. You know, it has to be something that after we've ensured that the mother is not producing any milk, that we speak with the pediatric doctors and they would recommend it for the baby. We have lactation counselors and stuff like that who would come in and help the mothers. Sometimes, yes, there are mothers who don't produce milk initially. There are mothers who would produce milk after a while, after they would have left the hospital. But we do have lactation people who come and assist the mother and help the mother and guide them through the whole process and stuff. Internationally, there are breast milk banks where they have milk, where the women who produce this extra milk, just like how we have a blood bank, they have breast milk banks where these women could go and contribute, donate milk to these banks. We haven't reached that high tech as yet, but I'm hoping that just as we could have a blood bank, we could have a breastfeeding bank, so that we could, you know, expose all babies to the joys and the benefits of breastfeeding. But as I said before, if you cannot produce milk, we have the capabilities to allow the mother to feed the baby while on the ward. One thing we will not do, however, is promote any particular breast milk brand, any supplemental feed brand or anything like that. We will give you what is available on the ward. Leaving the ward, that is completely your choice as to what you want to do. I hope that would have answered your question.
Thank you. Yes, it did.
You're welcome.
I want to just ask about the question about those the nipples. You mentioned about nipples. Is there a way to get those nipples to come out? I have my own way, but is there something that you could teach women how to get those nipples to be external? Because that's what the pain is, eh? I see my wife had black spots on her lip, biting that pain. But that was my fault. So, you know, after the second surgery, I did something to help it. But is there something that you put?
Well, on the ward, we have we teach mothers how to pull out the nipples. We use an inverted syringe where we actually put it on the nipple and we apply a suction to the nipple to help the nipples to come out. So it's a little thing to note that the nipple on the breast operates just like the nipple on the bottle. It is just a conduit for the milk to go through. The milk, what we need the baby to get is not the nipple. Once the baby holds on to the areola, which is that dark circle around the nipple, that's where the milk comes from. Once they hold and they apply pressure to there, that's where it comes from. So it doesn't really matter inverted nipples, short nipples, fat nipples, it doesn't matter. Once we can get that areola there for the baby to squeeze on, we know that the mother will breastfeed. And another thing too, we encourage like the mothers who feel that, you know, because there are some people who feel that this just ain't going to work and they may not have anybody to help them pull out the nipple. We encourage them to use the breast pump. So the breast pump helps the milk to flow so that the mother could feed the baby, not by bottle. We teach them cup feeding and other methods. And a plus to that is that the mother is able to engage other members of the family in the breastfeeding, like the husband, where the express milk he could use to feed the baby and build that bond. Because, you know, it's a little selfish thing the mother has between her and the baby. You know, when she breastfeeds, she and her baby locked in a world together and they lock out everybody else around them. You know, they have that bond. So, you know, that little breastfeeding day allows the daddy that opportunity, you know, to feel it for the baby to recognize somebody else there. But the nipples ain't much of a problem. We could fix that. Anybody wanting a nipple fixed, they could come by us. We could fix that for them.
I thought you would ask his fathers to help fix that too.
Well, we do help them too. We do ask them to help prior to delivery. You know, it's a little quote unquote. We tell them, you know, go home and do your homework. It's homework. We send the men home to do homework. So a list of homework that we send them to do, and bringing out the nipple is indeed one of them.
Very good. I have one more question. I was listening to Dr. Adish recently, and he was saying that there seems to be a problem of women waiting too long to come for medical checkups after they found themselves pregnant. Do you find that too in this community of Point 14, that women are taking a long time to come on?
Unfortunately, and Dr. Jovic could attest to that. Yes, we have some women who wait a bit too late. And, you know, as I said, they should start care early. But some of them, especially women who would have been mothers before, believe that they know what they are doing and they don't need to come until just about time to deliver. And unfortunately, we deal with situations where women would come in who would have had no antenatal care at all. And we are all, both the doctors and midwives, are going in blindly to their care. And especially if they're coming in labor, it's a crazy mad rush to check blood, to check position of baby and stuff like that. And it is an unfortunate thing that is happening within our community. And I'm hoping that, you know, that like forums like this would help, you know, to let women know it's early. The earlier you come, the better it is for you, the better it is for your baby, the better the outcome.
So could I propose that we could sponsor, like once every 2 months, a public forum, a public within your department? Is there some public health place we can come and have a session like this? Is it possible?
Well, I can't say yet, because there are a lot of things that are working in with the new hospital. A lot of new things are coming in. A lot of things are being put into place. So I don't know if those are one of the things that are in the books. As I said, we would have started our Lamaze classes and stuff like that. We do go into the clinics and we give little health education talks. And in primary care, which is the health center, you know, the district health visitors, they are charged with informing the public. So hopefully, I don't know, a collaboration between the two would help. But for now, we're working on ourselves in Point. We're still in the teething phase. We haven't begun to bite good yet.
Love that nipple.
So, Ms. John, we haven't forgotten you. What are the challenges you've consistently seen in Point 14 from your experience?
with regards to maternal and child health.
In general as well, because I know you delve in different areas as well, but I know we are focusing on maternal and child health. So yes, you can talk about that, but in general with from your experience.
For me, I have there's a lot of children that are not registered. So therefore, if they are not registered, they're not enrolled in school. So I think for the past probably 2 to 3 years, it has been a lot. And now I think they have to go further Spain for late registration. And that is a challenge because most times the persons they're not aware of how to go about doing it. Financially, they don't have the funds to go to Port of Spain. So there were times there that I've gone for myself, but it's the same process. Do you go in and I went in for the client, but it's the same process by which I have to stand up in the line, even if I have my badge on my forehead here, the same process. And I find that was a bit challenging. It's not that I'm not willing to assist. I have done it like 3 to 4 times, but it took a day, a whole day. And that's just for me. I think for me personally, that's one of the things that is really challenging, and it is increasing a lot. So yeah.
Is there like a way you can put in an advocate for us to have like a South office for late registration? Because I think a lot of it is finances. Most of them is because they can't afford. So
I think I have.
I guess that's
like 2 weeks ago, 2 to 3 weeks ago, I spoke to a client of mine who has 3 of her children. She was a teenage mother as well. And because of the father, I got her on her second pregnancy. And she didn't have she didn't have a birth paper. So didn't have a birth paper. The guy was older than her, and he was afraid that if he came or registered the children, they would have hold him or whatever. So she's like 20, 21. So I got her birth paper, but I think she told me that she went to San Fernando, right? And she got through with the late registration in San Fernando. So I'm not sure if there's a door that is open there. I'm not sure if she knew someone. I'm not sure. But I went to Port of Spain to get hers, but she said to me that she got through in San Fernando. So I need to talk to her a little bit more to find out if that door has been open and to explore it more for the others.
And in terms of last question, from my end, is that when you go and visit the people that we refer to, the moms, do you come across a lot of postpartum depression? And if you do you refer them to the psychiatric clinic or somebody who's going to help follow them up?
Yeah.
You do?
Yes, we do. So sometimes I have referred a couple to the psychiatric social worker. So you work hand in hand. Right? So the psychiatric social worker more deals with depression and those with psychosis and these type of things, right? But most of them do not believe that they are depressed, or they don't want that label upon them. So sometimes you need to explain to them that it's okay, it's natural, it's something that is normal, right? But yes, I have had not only with the teenage mothers, but across the board. Yes, that is on the increase.
So, well, we've reached almost the end. I thank you all again so much for taking your time and effort to prepare and just come out and speak freely as well in terms of giving us your insights in terms of maternal and child health. It was a wealth of information. I don't know if y'all have any final thoughts in terms of your presentations or talks. Ms. John, Ms. Monsegue.
I just want to say thank you for having me. This is the first time I've ever said yes to something like this. So it was a good experience, a great experience actually. So I thank you for having me. And that's it. Anytime again, you all can feel free to ask and I'll be here.
Okay, well, for myself, it is also the first time, I mean, I've given talks as a nurse. I've never had to give talks as a midwife, and it was a bit overwhelming. Not overwhelming, eh? It was a bit of a something that I was going to the point where I was going to say, hey, I'm not going to do this again. But I committed myself to doing it, and it was hard for me to have to disappoint somebody. But it was an exciting time. I was excited to prepare my slideshow. I had all my children here with me, teaching their mother what she doesn't know about computers. And you know, it was really exciting. I appreciate this opportunity because, you know, sometimes because of work, we don't get an opportunity to share information like this. And it's a lovely way, you know, to each one tell one. So, you know, I may not have a pregnant woman here, but I may have dropped a little bit of information to somebody that somebody could tell somebody to tell somebody. And I appreciate the opportunity that I was given. And dare I say, quite trepidatiously, I am open to another invitation if ever you should need. Trepidatiously, I give that invitation. But thanks so very much for having me.
I am here to officially what you call the vote of thanks. Both of you, Ms. John and Ms. Monsegue, thank you so much for giving up your time and service. And I want to especially invite you to think about being Rotarian. We Rotarians, 172 countries attached, over 36,000 clubs, and it is not just Point 14. And so it's a very large audience that you have people, communities that you can work with. And we are guided by several areas of focus, one of which is maternal care. We have conflict and peace, we have education, literacy, hygiene and water and hygiene, disease management, literacy, I said before, and economic growth and the entrepreneurship, empowerment. So these are the areas that we work with. And we have certain stratas. We are guided by our district governor who comes out of any island between St. Kitts and Suriname. And today I want to make welcome the assistant governor from the East Hester, that is Arima, Sandy Grande, Piaco area, Ms. Betty and Whiteman. Very happy to have you here, AG. And I was glad that you could make it. And we have members of the Point 14 Club. We have past district secretary Annie Rogers and our own treasurer Shirik O'Keefe Cupid and Gail Bellicon, and our membership chair Patty Ranson, of course, our past president. Our immediate past president, Sharon. I had some church members here and my students of the health and psychology program of the University of Southern Caribbean. Thank you guys. Sharon, to get maybe my community chairperson to come back in and put down some words here and talk to Chevy, Rotarian Chevy, and get you two ladies plus others and really get going. I think what we could do, Sharon, I'm saying this publicly here, we do have a new challenge from our district and for our to do empowering girls. And I think we can do something with teenage pregnancies, empowering young girls to be better. So I'm saying that here, and I am very excited about that. It's a project we can work with, and I will see how it goes. Yes, our teacher. Is that a good idea? She's smiling. So thank you again. On behalf of Rotary Point 14 Club, it was a pleasure to have all this share. Thank you.
Great. So, folks, that brings us to an end of tonight's proceeding, but I hope it's not your end with Rotary. So you can always just feel free to connect us. If you have our contact numbers. If you would have gotten this email from someone, most likely connect with them and get on to us as well. You can look forward to next month's Rotary Talk, which is focused on membership. So I don't know, I'll probably speak to the public relations officer and we'll probably bring a couple of the members and we'll interview them, right, about their experience and get to know a little bit about their journey through Rotary as well. And the ups, the downs, the good, the likes, right? We're going to find in deep there. So feel free to join us for that next session where we're going to dive into what does becoming a Rotarian look like? What does joining the membership look like, right? And get a feel for that. So I want to thank the speakers again. Press, thanks again. And if you all didn't hear Breast is Best, then it wasn't listening to the session. All right, folks. See you all next time and have a safe and great and enjoyable rest of your evening and good night.
Thank you.